All right, everyone. It's about that time for us to get started. So first off, hello to everyone and happy Friday. My name is Kayvon Kaboli, and in our webcast today, me and my coworker, CC Teague, we'll be taking a look at the different payment reform models that we're beginning to see spread throughout healthcare systems in the United States. Before we jump in, I wanted to just briefly give you a background on the two of us. I have been with Galen for a little over 3 years now, and I have a master's in public health, and I've worked in the healthcare arena for over 6 years now. My coworker, Cece, she's worked at Galen as a consultant for just over 4 years, and she recently became a certified associate in project management, and she's worked with a variety of clients in a ton of different roles. And now just for a little housekeeping, I just wanted to take a moment to remind everyone that all of the lines are on mute just to avoid any interruptions during the presentation. If you will direct your attention to your WebEx screen, you'll see there's a button in the top right of your screen that you can click on to open the Q&A panel, and feel free to submit any questions regarding the topics reviewed during our presentation. And these questions can be typed into the text box that's at the bottom of this panel. Just know that while we won't be answering those questions today, we will be delivering responses along with the slides for this webcast on the Galen Wiki within a week. And this information can be accessed by clicking on the Galen webcast documents link that's on the main page of the Galen Healthcare Wiki. Up next is our agenda for today. So to summarize what we'll be covering, our goal for this webcast is to give you a high-level overview of what our healthcare system is like today and then how we got to where we are. In doing so, we'll be touching on the fee-for-service reimbursement model, and we'll also discuss any potential shortcomings it may have. Along the way, we'll also discuss many of the deficiencies that are currently afflicting our healthcare system and how these deficiencies have led us to the crossroads we find ourselves at now, which is in the midst of payment reform. After that, once we've taken a look at our history, we'll then move on to discuss the various payment reform models. And the models that we'll be reviewing today are accountable care organizations, patient-centered medical homes, bundled payments, and a couple of different quality measure programs. And then for each of these payment reform programs, we'll also be defining what the program is, its current status, that is, how far along it is in being implemented, how it can help your organization, key things you as an organization will want to know should you choose to participate in any of these programs or if you're required to participate. And then finally, we'll discuss how we at Galen can help. All right, so let's kick things off by first talking about where we are now and why we're even exploring payment reform in the first place. So the first question is, what's wrong? Well, there's a number of things, but one of the best ways that we can point toward the issue is by taking a look at some statistics. One measure we can look at to get a sense of how well we're functioning as a healthcare system is to take a look at infant mortality rates. And despite recent declines, in 2011, the infant mortality rate in the United States actually remained higher than most other developed countries in the world. Our rate of 6.07 ranked the United States 26th out of 29 OECD countries, and this put us behind most European countries as well as other countries like Japan, Korea, Israel, Australia, and New Zealand. And then just for comparison's sake, the top 2 countries with the lowest mortality rates, those were Japan and Finland, and both had a rate of 2.3 deaths per 1,000 live births. So their infant mortality rate is significantly lower than what we're seeing in the United States. Similarly, the U.S. life expectancy of 78.49 years has us ranked 50th in the world. And again, we're trailing most of the European Union in this category, as well as some other countries such as Bosnia, Herzegovina, and Jordan. So some of you might be saying, well, that's not so bad, right? Or maybe you're saying that's terrible. But the reality is that these statistics, they're merely average, and they stand in sharp contrast to our annual healthcare expenditures and also our capabilities in medicine as a country, neither of which are average. To drive the point home, I have one more number that puts our healthcare expenditures in context with gross domestic product, which is the total value of goods produced and services provided in a country per year. In 2011, the U.S. spent $8,508 per person, or 17.7% of its gross domestic product on healthcare. And this number is much, much higher than the OECD average of 9.3% GDP spent on healthcare. The Netherlands was the second largest spender in healthcare, spending 11.9% of its GDP, but that's still a far cry from what we, the U.S., spent. On a per capita basis, the U.S. spent more than double the average of all OECD countries. And again, the point is that our expenditures simply are not in line with our expected outcomes. So why do we spend more and yet still get less out of our health care? There isn't a simple explanation for that question, as there's a number of factors that intertwine and compound to create the issue. You know, we could talk for days about how and why costs continue to skyrocket, but in the interest of time for today, we've attempted to simplify our view and narrowed our focus down to what we believe to be several root causes. So in broad terms, one root cause of rising costs is what is referred to as the acute treatment paradigm, and this is something that permeates our healthcare system today. The traditional acute care model presumes that there's an initial exchange of information between a patient and a physician, that the physician identifies the disease, remedies it, and then sends the patient on his or her way. But this approach, what it does is it disregards the potential for preventive measures, which could eliminate or prevent this disease in the first place before it becomes expensive to treat. Nor is this approach effective when treating long-term chronic illnesses, such as diabetes, which are actually becoming epidemic in our country, because rarely do individuals with chronic illnesses like diabetes have only one medical problem. So in other words, finding and fixing one problem for these people does little to help them or constrain costs because they have other medical issues that also need to be addressed. Other causes that are contributing to rising healthcare costs in the U.S. include overutilization and duplication of services, because regardless of necessity or outcome, insurance is always going to pay for the service. Fragmentation of care is another root cause of rising healthcare costs, and this could mean lack of coordination among various professionals that are involved in treating a patient, say, during a single inpatient stay, or fragmentation could also be viewed on a broader scale to include lack of coordination between different providers that a patient might see for treatment regarding different illnesses. The result in both of these instances is inefficient care, competing treatment plans, and often the duplication of services. And then finally, we have the big one, a major reason why we spend much more than other industrialized countries, but yet we still achieve worse outcomes, and that is fee-for-service. Fee-for-service, it's the most common reimbursement model in the American healthcare market, and it's been around since at least the 1930s. Under this reimbursement model, the way that it works is a predetermined amount is paid for each discrete service that's provided. One difference is that unlike most other consumer markets where the list price of goods or services are determined by what consumers are willing to pay, in healthcare, the amount paid for services is usually negotiated between insurers and providers. And the question, though, is how are these prices first determined? So you might be shocked to hear that the rates are often determined based on three simple nondescript tenets: what is usual, what is customary, and what is reasonable, or UCR for short. The healthcare.gov website defines UCR as, quote, the amount paid for a medical service in a geographic area based on what providers in the area usually charge for the same or similar medical service, end quote. And unfortunately, as you might be able to guess, setting rates in this manner, it hasn't really been effective, and it's also led to some egregious distortions in payments made for healthcare services. Another issue with paying for healthcare based on the fee-for-service model is that it offers little or no incentive for providers and healthcare entities to deliver efficient care or to prevent unnecessary care. Because of this, what fee-for-service does is it rewards volume, both in terms of the number of patients seen and the number of procedures or diagnostics that are ordered. So we all know there's a problem. The question is, where are we headed? During the last decade or so, various healthcare stakeholders, such as CMS, they've been exploring opportunities to control costs while simultaneously delivering more effective and efficient care to consumers. These cost containment explorations, they've generally favored value-based care reimbursement models as an alternative to the fee-for-service model. And as we found out earlier, by examining our current healthcare delivery system, we can unveil a number of common themes, and ultimately, these are the things that value-based care initiatives aim to fix. So the next question is, what exactly do we mean when we say value-based care? You might have heard of accountable care organizations, patient-centered medical homes, bundled payments, or even quality measure programs. Well, these are all payment reform programs that aim to shift healthcare away from an acute care paradigm focused on volume and intensity to one that's aimed at providing holistic, coordinated care with value at its core. Many of these programs also aim to shift or share risk between providers, payers, and consumers. And the hope, in the end, is to curb rising healthcare costs while simultaneously improving health outcomes, and the delivery of health care, whether it's by emphasizing preventative care to avoid costly inpatient admissions down the road, or by delivering only the most effective and appropriate care. So next, what we're going to do is we're going to take a look at the shape that some of these reforms are taking, how they might fit in with your organization, key things to know, and how we at Galen can assist with implementing and qualifying for each program. So to kick off the next segment, I'm going to hand things over to Cece so that she can discuss accountable care organizations, and then later on patient-centered medical homes.
Thanks, Kayvon, and welcome everybody to our webcast this afternoon. Thanks for joining us. And as Kayvon said, I'll start with some high-level points about accountable care organizations. First of all, let me define it in that an ACO, for short, is a formally organized entity consisting of physicians, hospitals, and other relevant health services professionals that they voluntarily come together and are responsible for, through contracts with their payers, for providing a broad set of health care services to their patients. And what ACOs are doing are they're creating incentives for healthcare providers to work together to treat an individual patient across these care settings, in the doctor's offices, hospitals, and long-term facilities, for example. And of course, the impetus for this change is to change the way, or this model, I should say, is to change the way providers are paid. Instead of the fee-for-service, ACOs are, or fee-for-service only, I should say, ACOs are rewarding providers that are able to manage chronic diseases and meet certain quality measures while at the same time constraining the healthcare costs. So if the quality of a patient improves and the costs are constrained, the members of these ACOs share in those associated savings. There are several different types of ACO programs, both commercial and federal, available to organizations to join. Today we are going to be highlighting, or referring to, I should say, the Medicare Shared Savings Program for ACOs, and this is one of 3 shared savings payment models that the Centers for Medicare and Medicaid Services defined. But you probably know, and I'll just make the point here, that there are many options out there for you to consider for ACO programs that are best for your population, patient population, and your payer mix in your particular area. But the goal of this coordinated care in ACOs is to ensure that the patients, especially the chronically ill, get the right care at the right time and avoid duplications of services. So they're emphasizing better care for individuals, improved health for the population, and lower growth in healthcare expenditures. Now the question that we'll look at next is how the members of these ACOs are actually being paid. So as we know, the traditional fee-for-service payment system where doctors and hospitals are paid for each test, this has been driving up healthcare costs by rewarding these providers for doing more, even if it's not needed. So the ACOs are not doing away with fee-for-service, but they are creating an incentive to be more efficient by offering bonuses to providers when they keep costs down. So in conjunction with keeping these costs down, doctors and the hospitals have to meet specific quality benchmarks that focus on prevention and carefully managing patients with chronic diseases in order to be eligible for these bonuses. So they are getting paid for keeping their patients healthy and out of hospitals. If an organization is participating in Medicare Shared Savings Program for ACOs, they are required to choose one of two models. The first is called a one-sided model, and that's where the participants share in the savings generated during the duration of their agreement with CMS. And the two-sided model, this is where participants share in both the savings and the losses during their agreement with CMS. So, and CMS is rewarding the organizations that choose a two-sided model where they're also exposing themselves to being responsible for the risk of loss during a patient's care by giving them a higher share of what's saved during the year on patient care. So what do these types of ACOs mean for you? Well, first of all, participating in an ACO is purely voluntary for providers, and it is also voluntary for the beneficiaries, so that patients maintain their right to choose any doctor whether or not they are participating in a particular ACO. And if an organization wants to participate in Medicare Shared Savings Program for ACOs, the providers and the hospitals and all the participants that want to be part of the one entity have to come together and to apply to CMS. And then to be accepted, this ACO entity must meet all eligibility and program requirements that CMS has set up. For example, with this particular ACO, the whole entity must serve at least 5,000 Medicare fee-for-service patients and agree to participate in the program for 3 years. And those are just a couple of examples of those requirements for that particular type, and each ACO that is developed has their own framework for how they define being a member of it. But they all are developing processes to promote evidence-based medicine and promote patient engagement with the ability to report on the quality of the care they're providing, along with that cost of care and the coordination of that care. And this is all related to maintaining a very strong focus on the participants receiving the right care at the right time and avoiding unnecessary services or duplication of them. So if you are not currently involved in an ACO, I'll just make a few points on just for some things for you to think about in preparation. And first of all, I'll just bring to, make this point. There was an article in Health Data Management that predicts that by 2019, 80% of the healthcare organizations will adopt some sort of outcome-based payment structure. So that the fact that we have this strong momentum to move from fee-for-service to these outcome-based payment models means, most importantly, that an organization just needs to keep abreast of these changes going on in the healthcare world. Because your organization will be needing to pay attention to what payment models are suitable for your organization and which ones you want to participate in. And in terms of your current structure, in your current payment environment for your patients and organization, just ensure that you're properly coding and that your billing procedures are strong and that you can be very attentive to your accounts receivable, so that if you're able to understand your current payment model, and that will allow you to fully understand the future changes that it will most likely be undertaking. And again, if you begin your relationships early with potential ACO members, people that you would want to partnership and begin those conversations early and brainstorming with each other and really talking about each other's goals, those kinds of conversations from both the provider and the payer perspective with potential partners is invaluable to start those sorts of conversations early. And of course, you will absolutely be spending time analyzing your own organization in consideration for this model or any of the models. And you really have to look at your board and your medical staff and all of your affiliates and just really think about your ability to be innovative in terms of how you improve your patient care and your population health while reducing costs, and know that the changes and being nimble with being able to achieve those goals, your organization will have to sustain. And another point that's actually kind of a bit of a large part to all of this is that many providers don't have the resources, or they're quite nervous about repositioning themselves into a different payment model. So as a healthcare organization, you'll need to understand how the ACO model that you participate can really help the providers transition to outcome-based payments. So these are just a few highlights on accountable care organizations, and I'm going to go on now to patient-centered medical homes, and then at the end of that I'll come back and just kind of summarize both of these together. So let's see. So what is a patient-centered medical home, or PCMH? A patient-centered medical home is a way of organizing primary care that emphasizes care coordination and communication that improves the patient's and the provider's experience of the care, and it leads to higher quality of care at lower costs. And the objective here is to have a centralized setting that facilitates the partnerships between the individual patients, their personal physicians, and when appropriate, the patient's family. So, and in addition to primary care organizations, this model can also be used for specialty clinics, like an orthopedic clinic, for example, and you can qualify and put yourself, you can have that model, and it's called patient-centered specialty model, patient-centered specialty practice, and it mirrors this PCMH model that we're talking about today. And like ACOs, this is a voluntary program where commercial payers are incentivizing both primary or specialty care organizations to provide comprehensive care at lower costs. A number of years ago, the American Academy of Pediatrics collaborated with 3 other organizations to define the characteristics that provide the standard definitions for this delivery model and the environment which is important for supporting a medical home. And some of these characteristics are listed here on the slide. The one is that patients have to have access to a personal physician who leads the care team within a medical practice. And this care team provides comprehensive care, including acute care, chronic care, preventative services, etc., across all stages of a patient's care in the care settings, healthcare settings. Practices will take steps to ensure that patients receive the care and services they need in this medical neighborhood in a culturally and linguistically appropriate manner. And practices use the quality improvement processes and evidence-based medicine to actually continually improve their patient outcomes. And they are always committed to enhancing the patient's access to their care, information about it, and being able to receive it when they need it. And they, again, in this model, practices will maintain their fee-for-service reimbursement model. However, because of the recognized value of the work that goes on outside of the face-to-face visits with patients, the coordination of their care, the collaboration about people taking time to speak about the best course of action for a patient, all of these added ways of providing care, the PCMHs are actually adopting enhanced payment opportunities to pay the providers and people in the clinics for this additional time they're taking to care for their patients. So again, the question that our theme here is, what does this mean to you? Primary care practices or specialty practices are transformed into these medical homes through a formal recognition process. There are actually a number of nationwide PCMH recognition and accreditation programs that out there that exist. However, the most comprehensive and widely used is the National Committee on Quality Assurance, or NCQA recognition program. And this recognition demonstrates that the practices and the clinicians that have achieved this value quality health care delivery using the latest clinical protocols, and it ensures that patients receive the best care at the right time, or the model is supporting that insurance, I should say. And this recognition also is how you open the practices to opportunities for the payment incentive programs that offer the bonus for improved quality and coordination of each patient's care. Now, building a PCMH medical home requires a lot of hard work for everyone in the practice. However, the accomplishments are proven of proven value, and they really allow a practice to respond to the move from this value-based payment system, or volume-based payment system, I should say, to the value-based payment system. And it really ultimately benefits the patients and the practice and the healthcare costs and spending. And there are extensive studies available for you to look at in terms of that have been gathered on the PCMH, how they've been doing so far, and they reveal there's a significant benefit for this model with reductions in inpatient visits, emergency room visits, and hospital readmissions, which of course is bringing down costs when those are reduced. And the data actually shows that patients are achieving better health and better care at lower costs. So this all shows that the investing in a medical home really offers both short and long-term savings for all parties involved, the patients, the employers, the healthcare plans, and the policymakers. And one point I have up here on the slide is about the cost of becoming a PCMH, and that, of course, varies depending upon the factors listed here on the slide. But the NCQA recognition program will provide a good roadmap for you to analyze your practice and what it will cost you to become a PCMH. On the next slide here, I've just put up this graph. I won't go into the details of it, but it's from a Patient-Centered Primary Care Collaborative, which you can go look at this graph, and it's a very good depiction of the benefits for the patients and providers to participate in the PCMH recognition program. And if you want to use this as a tool for talking about it within your particular organization, I just wanted to bring this to your attention so that you can go find this and use it as you will. So another big question is how can you prepare? And if you're interested in becoming a PCMH, you'll just need to go to the website that offers the recognition, and you will just educate yourself on the requirements for that are required to be, that you'll need to become qualified. And historically, this was originally a recognition program for physician-led practices. But if you live in a state where nurses can provide primary care and can practice independently, then the program is also including nurse-led practices for this recognition. And so the NCQA recognition program will step you through what's required and also how to analyze your readiness to become recognized. The process takes time, anywhere between 8 to 18 months, and you'll just plan accordingly as you head down the road that it's going to take. But one of the things I wanted to bring to your attention that's one of the first steps that you'll want in acquiring this recognition is to organize your own team. Because you're going to need a strong team right from your organization that probably includes a physician champion and a project manager. And very importantly, you want the leadership of your organization to be very behind the mission and the vision and the strategies of this model, so that they can really reinforce the value of it to your organization and bring enthusiasm for it. So, and again, the last point I have up here is about how you can prepare is one of the probably the best resources too, is to learn from others. And there are lots of information out there about practices that have achieved PCMH recognition, and papers have been written, and also the NCQA recognition program itself will be able to offer you ways of talking to other places that have already gone through the process before you, and they can kind of highlight what's been important to them and would be of value to you when you go through it. So, I said at the beginning of speaking about these two at a very high level, the ACOs and the PCMHs, that I'm just going to summarize both of these now. Because right now, lots of primary care physicians are finding themselves in where it's difficult to decide whether to become part of a patient-centered medical home, or become one, I should say, or affiliate themselves with an accountable care organization, because everybody's struggling with rising costs in the healthcare and the stagnant reimbursement and the frustration with the current payment system that rewards volume of service over quality. So because PCMH and ACO share the common goal of lowering costs and improving patient outcomes, they're often thought of interchangeably. But I just wanted to point out the difference. The difference is that the PCMH is an approach to care for an individual practice, whereas an ACO is a method for reimbursing a network of providers. So basically, the PCMH is a care delivery mechanism, while the ACO is a payment mechanism. And I'm going to hand things back over to Kayvon now, but I just wanted to reiterate what Kayvon said at the beginning, that if you have particular questions on your considerations for either of these programs, or if you're already in one and have questions about that, please feel free to put your questions in the Q&A, and we will definitely get to them. And not only will will we answer your questions, but for all of you on the webcast, what we discuss with everybody will be available to you on the wiki, within a week when we post it. So back to you, Kayvon. Thanks.
All right. Thanks, Stacey. So as Stacey mentioned, we have a couple other payment reform models that we want to take a look at before we're finished today, and one of those is our bundled payments, and within that, we're going to take a look at the comprehensive care for joint replacement, or the CCJR program, just to give you an example of how this reimbursement model functions. So the first thing that we need to do here is obviously to define what a bundled payment is. So bundled payments, they're generally considered to be a middle ground between the fee-for-service model and global capitation. And the goals of this reimbursement model, they're similar to those of ACOs in that they aim to align financial incentives of hospitals and surgeons around the common goal of coordinating care and improving quality and cost efficiency. What the bundled payment model seeks to accomplish, or the bundled payment model hopes to accomplish this by bundling the payment for a complete episode of care to create an incentive for providers to coordinate their services. And the second quote that I have on the slide, I thought it was an excellent excerpt, and it was from an article by Freundchen et al. And it points to how this reimbursement model looks at payment for healthcare from a different perspective, that rather than defining how providers get paid for each product, what bundled payments do is instead they seek to define the product itself for which providers expect to get paid. So I thought that was a good summary. And this brings us to CCJR. And what CCJR is it's a bundled payment program that Medicare created, and it's set to begin on April 1st, 2016. And the model start date was actually originally January 1st, 2016, but based on feedback from the public, the start date was adjusted just this past week, in fact, so that it's now April 2016. So what is CCJR? CCJR is a bundled payment program that specifically aims to address inconsistent and often rising costs for one of its most common inpatient surgeries, which are that Medicare beneficiaries receive, and those surgeries are hip and knee replacements. And a key difference between how things normally go and how this model works is that CCJR holds hospitals accountable for the quality of care they deliver from surgery all the way through recovery. And this means that a bundled payment for a total knee arthroplasty would cover the cost of both the inpatient stay and outpatient services. So as an example, these costs, they would include post-acute care costs, surgeon fees, rehabilitation costs, and any other ancillary fees. Basically, the entire spectrum of care required for a total knee arthroplasty bundled into one single payment. And because the bundled payment encompasses the entire spectrum of care, CCJR isn't going to affect just hospitals. It's also going to impact how ambulatory facilities get paid as well. So ensuring that your CCJR program is effective, it's going to require close collaboration between stakeholders in both inpatient and outpatient settings. So why and how did this program come into existence? As I previously touched on, total hip and knee replacements, they are the most common inpatient surgeries for Medicare beneficiaries. And in 2013, they accounted for more than 400,000 inpatient procedures with a cost totaling more than $7 billion for hospitalization alone. And the issue here, it's not just the total dollar amount that was spent on these procedures, but more so the disparity and inconsistency in costs across various healthcare settings. As the average Medicare expenditure for surgery, hospitalization, and recovery for these procedures ranged from $16,500 to $33,000. That's a pretty large range of costs. And this wide range of costs for these procedures, it's often caused by post-surgery complications, hospital readmissions, and extended rehabilitative care. And again, the rate at which these complications arise varies greatly. For example, the rate of complications such as infections or implant failures after one of these surgeries, it can be up to 3 times higher at some facilities than it is at others. And ultimately, these variations and costs are due to the manner in which patients are receiving care during and after these procedures. And the manner in which patients are receiving care is dependent on the facilities that are providing it. So in the end, the goal of CCJR, like most other bundled payment programs, is to address fragmentation of care. the CCJR program, what it does is it aims to do so by holding participant hospitals financially accountable for the quality and the cost of an episode of care. And by holding providers and hospitals accountable in this way, it incentivizes better coordination of care between hospitals and physicians and post-acute care providers. And the hope of CMS is that by incentivizing this better care coordination to save over $150 million yearly on these procedures. So what does this mean for you, and what are some key things to know about the CCJR program? As I previously mentioned, CMS recently changed the proposed start date so that the performance period now begins on April 1st, 2016, and it's going to run 5 years from there. And instead of spanning across 75 MSAs, the participants are now going to span across 67 different MSAs, and this was another recent update. And an MSA is basically, it's a metropolitan statistical area, and these areas have a core urban region that contains at least 50,000 residents. Some examples of the MSAs that are required to participate in the CCJR program include New York City, Los Angeles, and Pittsburgh's just another one off the top of my head. You can view a complete list of these 67 proposed locations on the innovation.cms.gov website. Another thing about this model, except for those entities that are already participating in Model 1 or Phase 2 of Models 2 and 4 of the Bundled Payments for Care Improvement Initiative, hospitals that are currently paid under Medicare Inpatient Prospective Payment System and that are also physically located in the proposed MSAs, they're required, keyword there, required to participate in the CCJR model. Hospitals outside of these MSAs, they're not able to participate as of right now. Under this proposed model, participants will be held accountable for the cost and quality of care from the time of surgery through 90 days post-surgery. And then, depending on the hospital's quality and cost performance during the episode, it may either earn a financial reward or it could be required to repay Medicare for a portion of the cost. And again, this payment is proposed as an incentive to make sure beneficiaries receive the coordinated care that they need and that this program is designed to deliver, with the end goal being to reduce avoidable hospitalizations and complications. Then at the end of each year during the 5 performance years, results will be compiled and the model will set episode prices for each individual participant. And throughout the pilot years, all providers and suppliers, they'll be paid under the usual payment system rules and procedures in Medicare. And then following the end of a model performance year, actual spending for the episode, it's going to be compared to the Medicare episode price set for each participant, and then depending on the hospital's quality and spending performance, it could receive an additional payment from Medicare, or it could be required to repay Medicare for a portion of the spending. So how can you as an organization prepare for CCJR? For one, participating hospitals can start by analyzing current post-acute spending and comparing that to the national benchmarks. And if you're seeing significant discrepancies between what you're spending and what the national benchmarks are, this could signal a breakdown in workflow, or it could signal that third-party partners are not performing optimally, or even that there's a gap that exists somewhere in your supply chain. You'll also want to be sure to look for duplicate services and testing that could be eliminated to help reduce costs while also not negatively impacting patient care. Another helpful practice is to establish standardized protocols because, as we all know, best practices often lead to greater efficiency and even more predictable outcomes. Staff evaluations will also need to be made to determine if you have the right people in place, or if the people you have are open and willing to make the adjustments necessary to achieve the effective care coordination that's required by the CCJR program. And then finally, you'll want to be sure to assess the technological capabilities of your organization. So can care coordinators easily identify high-risk patients? Are the current tracking methods scalable? Is your team able to share records and communicate effectively with partner organizations? And how will you monitor patients once they leave the hospital? Those are all important questions that you need to have answers to. And another critical role in the CCJR program is played by the technology that you have in place. So when you're assessing your information technology, you'll want to look for solutions that can do a number of things, such as analyzing risk, because you'll want to be able to identify patients that may need additional communication or monitoring. Or you'll also need to be able to customize care plans, because all patients are different. You've analyzed the risk and determined a patient should be able to go directly from acute care to home health, skipping the skilled nursing facility. Your software should be able to handle these kinds of exceptions as well. You'll also need to be able to notify staff when patients fall off plan so that action can be taken immediately. And again, as we all know, communication is always key, and it's not easy. Your technical solution, it needs to be able to keep all parties involved in patient care and informed of the plan, and not just the plan, the risk level and what the expectations are for each patient as they recover from these procedures. Engaging patients is another critical component. How else will you know what happens to your patients once they've left your facility? How will patients know what to expect in terms of their care? Does your solution provide patients with a means of notifying your organization when risks arise? These are all things that your technology needs to be able to do. And then lastly, to improve efficiency, you need to report. You need data that will illuminate what partners are performing well, identify providers that may not be following protocols, and even analyze things like readmission rates and length of stay for the various phases of care that patients receive. And you need to know how these things impact your organization financially. So that wraps up our segment on CCJR. And again, later on we will talk about how Galen can assist you with this program along with the others. But for now, we have one more payment reform grouping that we'd like to discuss, and those are the quality measure programs. And as you can see from this slide, there are a number of them that we're going to go through today. So the first one that we want to discuss is the Medicare Chronic Care Management Program. And this program initially began in January of 2015. And in the simplest of terms, what this program does is it creates payer coverage in the form of a CPT code for spending 20 minutes per calendar month directly monitoring patients with chronic conditions. And this CPT code, which is CPT 99490, it can generate a CMS payment of about $42 per patient per month. The monitoring that the CPT code requires, it can be done in the form of a phone call by a clinical staff member to check on the patient's well-being, or, for example, to see if the patient's still taking their medications, or even to assess other key clinical measures such as diabetic glucose levels. Under this program, for a patient to be considered eligible, they must have 2 or more chronic conditions that will be treated for no less than 12 months and all the way up to the entirety of the patient's life. Another important thing to know is that the patient must consent to participate in the program, and that there must be a comprehensive care plan established, implemented, revised, and monitored throughout treatment. So on this slide, we have a list just to give you some examples of the types of conditions that would qualify for participation in the CCM program. And there are many more illnesses that qualify than we have on this slide. And in fact, CMS has estimated that as many as 35 million patients in the United States are eligible for participation in this program. So in the CCM program, which healthcare providers are eligible to participate? Unlike some of the other quality programs, in addition to just physicians, CCM allows for midwives, clinical nurse specialists, nurse practitioners, and physician assistants to participate. And one point to make is that the designated CCM clinician, whether it's an MD, a PA, or NP, they must manage the electronic care plan that addresses the needs of the patient. And the key word here is electronic care plan, and this means that the practice must use a certified EHR to bill CCM codes. It's also important to note that only one clinician can bill for any given patient during a monthly billing cycle. So what does that mean for you as an organization? It means, again, that coordination is key. You need to be able to coordinate among all eligible providers and subspecialists to ensure that you maintain compliance with the CMS regulations. And then what exactly needs to be included in a, quote, comprehensive care plan? Typically, a comprehensive care plan, it needs to include all the items that are listed on the slide. And again, the attempt here is to provide the holistic care that patients with chronic illnesses and chronic conditions need. And while this program does present a great financial opportunity for healthcare providers, it also addresses a key issues that providers feel strongly about, which are their interactions with patients that are suffering from chronic illnesses. And in fact, a recent poll of 45,000 primary care providers and current participants in the CCM program found that 84% of physicians believe the program is having a positive impact on patient care. So it sounds like we have something good going on here. We have a program that's supported by payers. It saves providers time, and it addresses a key area of concern, and can even save the patient a trip to the office. So just quickly, I want to touch on, again, some of the key things to know about the CCM program. Again, it started in early 2015, and the average reimbursement from CMS for the CPT 99490 code is $42.60 per patient per month. And if you span that over 1 year, that could amount to almost an additional $500 or so per eligible patient per year. And depending on your organization's payer mix, that could equate to a pretty large uptick in your bottom line. Also, don't forget that the practice must have written consent from the patients to bill for CCM. And again, that only one clinician can bill per month for each patient. Under the CCM program, co-payments do still apply, and there are other specific CPTs, which we've listed on this slide, that cannot be billed in the same month as the CPT code that was created specifically for the CCM program. And then finally, the last key thing I want to point out is that the time counted towards the monthly 20-minute bucket, it cannot include time that is also billed as E&M or procedural services. So that ends our overview of CCM. The next quality reporting program that we wanted to touch on is HEDIS, which stands for Healthcare Effectiveness Data and Information Set. HEDIS actually originated in the late 1980s, and it was the product of a group of employers and quality experts. And then it was later entrusted to the National Committee for Quality Assurance, or NCQA, in the early 1990s. Currently, NCQA information is utilized by more than 90% of America's health plans to measure performance on care and service. And they do this to make it possible to compare the performance of various health plans on more of an apples-to-apples basis. And again, the idea, of course, is to be able to provide consumers with the information they need to accurately and reliably compare health plans. So HEDIS behaves in a fashion that's similar to some of the other quality programs. It has 81 measures that span across 5 domains of care, which we have listed on the slide. And then in order to remain relevant in a healthcare atmosphere that as we all know, is constantly changing, HEDIS measures are added, deleted, and revised annually in a very structured manner. And in that same mode, all HEDIS results, they must be audited by an NCQA-approved firm for public reporting. And the reason that this is done is to ensure the integrity of all the data that is provided to consumers and end users. Another thing just to note is that Quality Compass is an online tool that is utilized by NCQA, and it can be used for reporting purposes. So let's go ahead and then move on to a brief discussion of PQRS, or the Physician Quality Reporting System. And as per CMS, and I'm going to read you a quote here, the Physician Quality Reporting System is a quality reporting program that encourages individual eligible professionals and group practices to report information on the quality of care to Medicare. PQRS gives participating eligible professionals and group practices the opportunity to assess the quality of care they provide to their patients, helping to ensure that patients get the right care at the right time. PQRS definitely is not a new program, and it actually started out as PQRI, which stands for the Physician Quality Reporting Initiative, and it's definitely evolved over its lifetime. Probably one of the most important things that's changed about PQRS is that while it may have started as an incentive program, in 2015 it actually changed into a penalty program. And in fact, negative payment adjustments on the Medicare Part B physician fee schedule, those negative payment adjustments are now being felt by organizations who failed to report satisfactorily in the year 2013. So how does PQRS work? Basically, the eligible professional chooses at least 9 individual quality measures that span across 3 domains, and they report on these. And these quality domains, again, we have them listed on the slide. And as you can see from this list, the quality domains are just that. They're centered on providing quality care. And in PQRS, eligible professionals, or EPs, they're required to report on at least 50% of Medicare Part B patients that they see, and in some cases, eligible professionals are also required to report on 1 cross-cutting measure. So that wraps up our high-level overview of PQRS. Now I want to touch on the last quality program, which is meaningful use, and we really just want to take a quick glance at what's new, what's gone, and what stays with the modified MU2 ruling that was published by CMS last month. I'm sure you're all aware of meaningful use by now, so I'm not going to spend any time explaining what it is, but I just wanted to let you know that we do have this slide here as a reference for you if you want to come back to it later. So having said that, let's jump right in, and let's take a look at what's new. So with the modified ruling, as you can see on the slide, there's a number of items that are new. First off, like PQRS, eligible professionals can now be penalized in this program for not demonstrating meaningful use. Another item that's new is that there's now a 90-day reporting period for both core and clinical quality measures for 2015. Now it's only required that you have 1 patient view, download, or transmit his or her information during the reporting period, whereas previously 5% of patients were required to do so. Something else that's new is that instead of requiring that 5% of patients send or receive messages, to receive credit, clinicians only need to demonstrate the ability to generate secure messaging. There's also now a single set of 10 objectives for eligible professionals, regardless of stage. And finally, there's no longer menu objectives to select from in the modified stage 2 objectives. So what goes? The original, as we all know, the original intent of MU was to focus on using EHRs to improve patient care, and then the later stages were to focus on patient quality outcomes. One thing to note is that while many of the core measures that have been removed, which again are listed on the slide, they are still required to some degree as part of the clinical quality measures. So for example, blood pressure and smoking status still need to be captured in order to meet requirements for some of the other programs such as MU clinical quality measures, PQRS, and PCMH, even though they were removed from the core objectives. And now we're going to take a look at what stays. There's 10 objectives listed on this slide, and they are still required in modified stage 2. All providers, whether they're attesting to stage 1 or 2, they will report on the exact same measures, but there are some caveats. For example, if eligible professionals are reporting on stage 1 in the modified stage 2 objectives, they will see lower thresholds for many of the objectives. And with that, kind of an abrupt ending, but believe it or not, we've now reviewed all the material we wanted to go over today for each of the payment reform models. And we know that it was a lot of information to digest, especially in one sitting, which is why we want to switch gears just for a bit to tell you how we at Galen can help you out with all of this. Because the truth is that most of these programs, they are very similar, and many of them even actually share common measures. And after all, each of these programs aim to address the same problems that afflict our healthcare system. Every program that we've touched on today, we can and we have helped clients with. We have professional services, we have technical services, and we have product services, each of which can help your organization keep up with the rapid changes in healthcare. Our professional services team, we can help you to assess your organization and choose which program is the best fit for you. We can identify current gaps in your practice and help you make the fine-tuning necessary to be an efficient organization, whether that's through the development of care plans, the development of written policies and procedures to support initiatives, or whether it's through configuring quality measures in your EHR, or training and educating your team and end users on the new workflows that are centered around these, supporting these payment reform models. Our technical services can also assist your organizations with items such as custom reporting needs, as many of the EHRs right now don't have the level of reporting necessary that's needed to meet the requirements for many of these programs. Additionally, our technical team can assist with the integration of solutions. Our ability to pull quality reports from your EMR or EMRs and practice management systems gives you not only the clinical and financial data, it gives you the clinical and financial data that you need to help your organization know where it stands in terms of qualifying and meeting the requirements for any of these programs. And then finally, we have our product offerings. We have Pinpoint, which is an additional software outside of the EMR, and what it does is it assists with the care coordination specifically for orthopedic practices. We also have a note form reporting tool for clients on V11 TouchWorks, and this will help and allow you to track and capture every field as discrete data regardless of how the documentation was entered. So to wrap things up, we know that making the link to these new reimbursement models is difficult. All organizations are going to have to rethink the way that they deliver health care. But the bottom line is it can and it must be done, and we're here to help. Finally, here we have all our references. This slide is a good source of information for each of the topics that we discussed today, should you choose to research them further on your own. Please note that we also have included at the bottom of the slide a link to a few of our blogs. One of them is on the CCJR model, and the other blog is on quality reporting and compliance success stories. And then finally, if you have comments regarding today's presentation or any questions on where to start or how to begin preparing for these reimbursement programs, please don't hesitate to send those questions or comments to us at transformation@galenhealthcare.com. And the last thing I want to mention is that even though we're finished presenting, we will be leaving the webcast running to give you some more time should you have any more questions that you'd like to send in via the Q&A panels. Otherwise, that's everything that we wanted to talk about today. We hope you found this webcast informative, and we thank you for joining us today. I hope everyone has a great weekend.